All right. So welcome to this basic training. My name is Dr. Landers. I'm an attending internist and pediatrician at Emerus Medical Center. And with this basic training, I'll give you a brief introduction to medicine at Emerus Medical Center and to give you a very short overview of what your work will look like. And I'll teach you a couple of techniques that might be useful for you. So first of all, there's a couple of learning outcomes that I'd like to discuss. So in this video, we're going to discuss the organization of Emerus Medical Center, admission and primary survey, care request exploration, vital signs, and ATLS, so advanced traumatic life support. So first, a bit about the organization of Emerus Medical Center. In other words, there's a couple of questions you can ask yourself, like what is a residency and how can you specialize? And what are your tasks actually as a resident? So residency normally is a 5-year program in which you specialize in a general field of medicine. And at Emerus, we offer 3 different programs. We offer internal medicine, general surgery, and emergency medicine. Now, internal medicine means that you'll be spending most of your time clinically or at the emergency department. And you'll be seeing patients who require acute care, as well as patients who require chronic care or long-term care. General surgery is the residency program that focuses primarily on surgical treatments of patients. And emergency medicine focuses on acute care and intensive care medicine, as well as some degree of anesthesiology, so working together with the surgeons. And these 5 years are called PGYs, which stands for postgraduate year, because you start residency after medical school normally. So you are an MD, and now you're starting residency into a specific field. Now, PGY1 and PGY2 are not that interesting. PGY1 is where you do an internship, and you also have a shadowing period. And it's also where you learn some of the basic skills necessary to progress. And PGY2 is meant to finalize these basic clinical skills. So starting at PGY3, you'll be more independent, and you'll also get to choose your specialization track. So internal medicine, general surgery, or emergency medicine. As a PGY4, you will finalize your clinical skills and start training your clinical leadership. And at PGY5, you will be preparing for your board exam. Residents actually see most of the patients that we have. Some of them are checked by nurses, but most patients are seen by residents with help from the attendings. So the shadowing period is a small period during the PGY1 year where you get a brief introduction to care at Emerus. Essentially speaking, you won't be actively treating the patient yet, but you will shadow another resident or another doctor and gain empirical skills, meaning you will kind of get your own interpretation of what it is like to be a doctor based on watching other doctors. And you'll be learning from experienced physicians or physicians in training, so the residents. And the way in which you move out of shadowing is by showing participation, being active, and also showing what you've learned, not just from this video, but also from what the physician or physician in training has told you. The shadowing period is usually for about 1 or 2 shifts, but it can take longer if you do not attend shifts frequently or do not show active participation. Now, the board exam, I just mentioned it before, but you may wonder what that board exam actually is. And the board exam is a final examination that you do before you are allowed to practice as an attending physician or attending surgeon, of course. Now, you can either do that or you can continue your education as a fellow, because there's many different medical specializations. After your residency, you'll be able to be an attending in 3 different fields: internal medicine, emergency medicine, and general surgery, which means you'll be an internist, you'll be an emergency physician, or you'll be a general surgeon. But these are rather general fields, and some people like to specialize into for example, a specific patient population or in a specific category of disease. And that's what the fellowships are for. Now, the fellowships associated with internal medicine are, for example, cardiology, pediatrics, neurology, nephrology, and medical oncology. With emergency medicine, you could do intensive care medicine or anesthesiology. And with general surgery, you could, for example, do cardiothoracic surgery, neurosurgery, orthopedic surgery, and pediatric surgery. This is, of course, not the complete limit. There's more departments in which you could specialize. There's also rare departments in which you could specialize, like infectious disease or immunology. So the department you specialize in will really depend on whether you can find a mentor for this. Because in order to do a fellowship, you have to be mentored by an attending or higher. So an attending cardiologist, for example, will be guiding you in case you want to pursue a fellowship in cardiology. Now, there's a lot of different types of care, and these departments all deal with different types of care or a different distribution of the kind of care that patients receive. So acute care is rather characteristic of emergency medicine. In this case, you have relatively short visits and immediate admission. So they are emergency patients or maybe even trauma patients. And usually there's only a one-time follow-up. So there's one-time follow-up where you ask if the patient has any more medium or long-term complaints. For example, if a patient had received a stab wound, you can do a one-time follow-up to check up on the wound, to check up on the patient's psychological status, and to perhaps follow up with some other radiology to check if there's no internal problems, as well as, for example, check for the risk of infections. Short-term care is more characteristic of surgery, although it of course occurs in all departments. These are also short visits, but there's usually no admission, or this admission is post-operatively. It's also usually with a one-time follow-up. For example, when someone's had surgery for an appendicitis, they can get a one-time follow-up where they get checked on how they're doing, whether they're experiencing any symptoms, and they can get a routine checkup to also see if there's any infectious disease present at that moment. Finally, there's a long-term care, which is more associated with internal medicine and also other internal disciplines like cardiology and pediatrics. These can be longer visits, and sometimes this requires admission, but in a lot of cases, patients do not require admission, and instead you can do this clinically. And these patients often have multiple to many follow-ups on sometimes a regular basis. In case of medical oncology, in the early phase of having a patient or diagnosing a patient with cancer, you typically see them every 2 weeks, sometimes even more frequently. And on the long term, after they've been treated, you can see them every month, every 3 months, every 6 months, maybe every year, up until you're pretty sure that there's no recurrence of cancer, and you can safely send the patient home and have them only call you when they suspect anything. So these are the 3 general types of care that we offer at Emerus Medical Center. So now that you know a bit more about how Emerus is organized, it might be more interesting to actually dive into some material, because you will be admitting your first patient here. And the way in which we admit patients is a rather structured process. And the reason why we explain this to you is so that you won't skip over things or forget things while admitting a patient. Primary survey refers to the questions you ask a patient after they are admitted. So where you ask them for things like their basic symptoms, their medical history, or their current take of medications. So during admission of a patient, there's a couple of things you always have to ask for first, assuming that the patient is not in an urgent, emergent, or critical condition. You always ask for their name, age, gender, specifically their biological gender, BMI, or otherwise their height and weight, and then you can calculate the BMI, and their chief complaint. And there's several reasons as to why you would like to know this, or perhaps have to know this. The name is, of course, for personal reference, but all other items help you with your differential diagnosis, so they will help you in thinking about what the patient might be suffering from. The age is also important because some medications are age-based and you cannot give them to, for example, people who are young or people who are very old, or you have to adjust the dose based on age. Gender is also used for personal reference. BMI is also useful for medications because BMI is because people with higher weight or higher body surface area may require different doses of drugs as well. And also to provide health advice in case their BMI is severely elevated or if it's way too low. And their chief complaint, what we mean by that, is the main complaint or the primary symptom that the patient is suffering from. And then you can wonder, are you allowed to admit every patient? Well, no. This is Roblox, so not everyone's going to be as serious as you'd like them to be. So not all patients can be admitted. And examples, or the three main categories of people who we do exclude are rare or untreatable infectious disease, cases related to pregnancy, sexuality, or abusive behavior, and unrealistic cases or inappropriate cases. In the case of infectious disease, we do not admit patients who we suspect to have Zika virus, Ebola virus, HIV or AIDS, SARS-CoV-2, or Creutzfeldt-Jacobs disease. These are all kinds of rare infectious disease for which we do not currently have adequate cures, except for HIV and AIDS, which we can treat in real life, but we will not here. Creutzfeldt-Jacobs disease is a rare type of infectious disease called a prion, P-R-I-O-N, and it's a kind of disease that causes severe bodily dysfunction, and there's no known cure to it, and these patients often don't survive for very long. But it's a very rare disease, and it's a tropical disease, so we do not treat it. We do treat patients with hepatitis B, considering it's not a tropical disease, but it's a disease that can occur everywhere. And hospital personnel are always vaccinated against hepatitis B to prevent them from getting it or spreading it. Historically speaking, if you look back to a period of 60, 70 years ago, surgeons who would often work with blood, of course, would often get hepatitis B from their patients or from one another. And as soon as the hepatitis B vaccine became available, healthcare physicians and nurses and other supporting staff in the OR, for example, were all encouraged, and nowadays it's even mandatory to be vaccinated against hepatitis B when there's no contraindications. Tuberculosis, Legionella, tetanus, and Staph aureus are also cases that we do admit. Then there's cases related to pregnancy and sexuality or abusive behavior. Now, we do not admit patients who show signs of self-harm or suicidality, as this goes against Roblox rules or guidelines. Pregnancy, erection disorder, vaginismus are all kinds of pregnancy-related or sexuality-related conditions that we also do not treat. The cases of rape are also examples of sexuality and abusive behavior and therefore are not treated. We do admit patients with lower abdominal pain. So a patient with lower abdominal pain doesn't always have to have something related to sexuality or pregnancy, so we do admit those. Urinary tract infections we also treat. We can also treat victims of violent crime, such as stabbing wounds or gun wounds. And babies, so even newborn babies we still treat. And then finally, there's unrealistic cases or inappropriate cases. Well, whether to admit or not is really open for your own interpretation. But a couple of cases we do admit that might seem inappropriate are, for example, rectal prolapse, which is where part of the rectum actually prolapses out of the anus. A foreign body aspiration, which is where, for example, a child swallows or aspires, which means that it gets into your respiratory system, a small battery. Or workplace injuries. Sometimes people think that they cannot admit certain workplace injuries, but workplace injuries are also admissible. All right, now that we've covered that, we can get to our primary survey. So we finally admitted our patient. We know their details. We know their case is realistic. What do we do then? Well, there's a nice mnemonic for this called sample. So when someone asks you to get a sample of a patient, they typically mean this. And a sample is an acronym that stands for symptoms, allergies, medications, past medical history, last oral intake, and events leading up to visit. In case of medications, in-game it's not possible to say that because Roblox will filter this, so instead say medxs or medx-ication. That way you can circumvent the system and still make yourself clear. Now symptoms, of course, stands for all of the symptoms that the patient is currently experiencing. Allergies are all the allergies that the patient has. Medications are the medications they currently take. Their past medical history is relevant medical history. Their last oral intake is what they last ate. And events leading up to visit is what they did prior to visiting. And here are some example questions that you can use. So for the symptoms, you could ask what their reason is for visiting you today or the hospital today. And you can also ask for additional complaints once they did mention their primary complaint. When you ask for allergies, you can simply ask, do you have any allergies, or are you allergic to, for example, this medication? Of course, you cannot ask them definitely, so you'll always ask, do you have any allergies that you know of? For M, you can ask, do you currently have or take any medication chronically? Or you could also ask, what kind of medication did you take before coming here, or did you take in the past few days? For the P, you can ask, do you have any chronic illnesses? And you can ask for any other medical history. For L, last oral intake, what did you last eat or drink? And also, very important, how long ago was that? And then lastly, what did you do prior to visiting? And also, what made you decide to visit us? That's a very important question to ask because patients may experience a multitude of symptoms, but there might be one event or one thing that causes them to actually decide to visit, for example, the emergency department. Maybe it's a concerned family member. Maybe it's a new symptom that they really don't trust. Maybe it's the chronicity, so they have had this for 6 months and they're now really, really done with it, and they now are really convinced that it might be something. Those are examples of answers that you could receive. Now here's some clinical vignettes, or vignettes, not sure how to pronounce that. Either way, clinical vignettes are kind of useful comments or useful tools that you can use for each of these letters. So in case of symptoms, never ask, what are your symptoms? Because the patient can not understand, or the patient might feel rather objectified. So instead, we ask them why they're coming. When you ask them, what are your symptoms? They'll give you an entire list of their symptoms, but we don't just want to know their symptoms, we also want to know what's bothering them the most. A patient could say that they have a cough and an itch, but you don't know if it's the cough that's really bothering them with a very small itch, or whether it's a very, very severe itch with an occasional cough. And you can only get that difference when you ask them what they're coming for. So for allergies, always confirm allergies again before giving hyperallergenic medication. And hyperallergenic medications include, for example, the penicillins, which are a type of antibiotic you can give for bacterial infections, and also the carbamazepines, which are types of anti-epileptic drugs. They're also hyperallergenic, so can often cause allergic reactions. Then there's medication intake or drug intake. Note that if a patient role plays to lie about this, and you notice this, or you think, or you have clear signs about this, mention that it's not allowed to do that. The reason why is because people will often purposely hide this for the sake of role play, whereas the purpose of the role playing is not necessarily for us to figure out what kind of medications the patient takes, because it's often difficult to find that out. So we do not do that. So for past medical history, do not ask for specific conditions, of course, unless there's very specific indications for that. For example, when someone presents with a lot of different symptoms that could be linked to diabetes, and you can ask them, do you have diabetes? And the patient might say yes, and then they haven't taken their medication for months, and now they're at the emergency department having a hyperosmolar state, for example. It only includes relevant history. If a patient comes in with coughing up blood and severe dyspnea, you're not going to ask them about their pinky toe that they broke when they were 5 years old, because it's very unlikely to be relevant. So make sure to only include relevant history. For last oral intake, you can classify food into solids, liquids, or mixed. The reason why is because some patients, for example, with swallowing disorders, can only ingest solids or only liquids, or can still ingest both, or can ingest neither. So it might be useful to classify foods. For example, patient ate solid foods 2 hours ago, or patient ate liquid foods 2 hours ago. It also makes a difference in terms of how fast they are metabolized and how fast they are used up by the body. And if there's been no oral intake for over 8 hours, you can write NPO, so which is Latin for nothing by mouth. Normally, you use the abbreviation NPO when you want to say that the patient should not eat, for example, prior to surgery. But if it's true that there's no intake for over 8 hours, for example, because the patient was very nauseous or vomiting, or because the patient had been sleeping for a long time and then visited you in the early morning without having breakfast, you can still write NPO in their file, just in case there is a surgery scheduled or a surgery supposed to be scheduled. That's when you can do this. And E, so the events prior to coming. The reason is very important for your DDX, so for your differential diagnosis. If it's all because of one symptom that seemed very severe to them, that might be an alarm symptom, and it might be a good reason to take a good look at why the patient reports this. So that was part 2. Now we go to part 3, the care request exploration. So what complaints does my patient have, and how do I assess my patient's medical history as good as possible? So I've mentioned primary and secondary symptoms a lot by now, but what do I exactly mean by this? Well, the primary symptoms are patients that are the symptoms that a patient either first experienced, or it's the most prominent symptom that they're experiencing. So it's often the symptom that they'll start with telling you. They'll, for example, say, "Oh, doctor, I've had very severe shortness of breath, so dyspnea, for the last 2 months, and I also started to notice a rash on my left arm, and I've also noticed my eyes twitching." So the primary symptom here is likely the dyspnea, and the secondary symptoms are the itch on the left arm and the eye twitching. And formerly unnoticed symptoms are also classified under secondary symptoms, but are typically called signs. We often ask for signs and symptoms of a disease. Symptoms are things that a patient notices, and signs are things that a patient does not notice up until physical examination. Now, there's 2 different methods by which you can explore a care request. Both of the methods are typically designed for pain, but they can be used in any case that's relevant. Just know which questions to ask and which not to ask. Some are very pain-specific and some are rather general. So be sure to omit the ones that are pain-specific when you want to explore a symptom that's not pain-related. All right, so first we start with the OPQ-RSTU method, which stands for onset, which means when did it start, provoke or palliate, which means are there any things or any factors that make your symptom worse or make the symptom better? For example, can you, when you use acetaminophen or aspirin, does the pain go away? Or you can, for example, say, well, does the pain get worse when you do nothing, or is it worse in the morning or in the evening? Then there's quality of pain, which is, for example, dullness, so a dull pain, a sharp pain, a throbbing pain. Those are also kinds of descriptions that you can ask for. Then there's radiation. So That's where you ask, well, where does the pain start, and are there any regions towards which it radiates? So, for example, in the case of a myocardial infarction, male patients at least, might often experience chest pains that radiate to their left arm. And in patients with appendicitis, they often experience central abdominal pain that radiates to their right lower abdomen. The S stands for symptoms, so the other or associated signs and symptoms that the patient is experiencing. T stands for timeline, which is essentially, for example, if it's continuous, so the pain is always there, or intermittent, which means that the pain comes and goes. You can also ask for when the pain occurs. So is it more in the morning or more at night? Is it after you exercise or after you rest? Is it kind of pain that happens when you do a certain thing? Or, for example, a symptom that occurs after eating or before eating? Anything of that matter. And the U means you. So it's for your patient's interpretation. You could, for example, ask your patient whether they are worried, or you could ask them to grade the pain or to grade the severity. You can ask them if it interferes with their daily life or with their quality of life. And those are all kinds of questions that you have to ask as well, because that's the best way to grade severity. A patient can grade their pain a 9, perhaps because they have a low pain threshold. But then when you ask them whether it has changed anything in their life, you can say, well, I've had this pain for a couple months, but I can still go to work and I can still exercise and I can still do my daily tasks. Then you can think, all right, perhaps the patient has a lot of pain, but apparently it's not sufficient to stop doing their daily tasks, which are clinically speaking, and also for the patient, most important. And now, as I mentioned, pain can radiate to different areas, and this is an image that might be very useful for you, because referred pain stands for pain that you feel in an area that's different to where the organ actually is. And over here, you can see the heart. As you can see, it starts on the left side of the chest and radiates to the left arm, and the appendix, which is on the right lower abdomen. That's where you can feel pain occurring in a certain organ or in a certain structure in the body. You don't have to memorize this entire image, but they are useful to remember. Now, the second method is the Socrates method, which has, essentially speaking, the same questions, just in a different order, and they're, in some cases, a bit more expanded or a bit more abbreviated. So Socrates stands for site, so where the pain is, onset, character, which is the same as quality, radiation, associated symptoms, timeline, exacerbation and alleviation, which is the same as provoke and palliate, and severity, which is the same as the U, as well as some parts of the quality of the OPQ or SCU method. So then we get to the vital signs, so item 4. Vital signs are something that you often hear. It's abbreviated with V and then a slash or a dash and then S, so vital signs. And they are indicators of general health. And there are 5 major signs, so the 5 major vital signs, which are heart rate, blood pressure, respiratory rate, arterial oxygen saturation, and body temperature. So let's start with heart rate. The definition of heart rate is the number of heartbeats per minute, which we count in whole amounts, so not half a heartbeat per minute, for example. We don't really do that because it doesn't add any value. Now, the normal range for a heart rate is about 60 to 100 beats per minute, or BPM. But this range differs depending on your age, because what we see in children is that when children are below the age of 10, their heart rate can range from 70 to approximately 120 or 140 in some cases even, and it's then still considered normal. And when a child is younger than 1 year old, the normal heart rate is considered 100 to 160 BPM. And having a heart rate below 100 is actually considered dangerous in neonates, so newborn children. Of course, this doesn't mean that if you see an adult with a heart rate of 101, or 59, that you should panic, because having a slightly elevated heart rate might be a sign of, for example, stress or being scared, or just in general, the risk of potentially having a disease. Some people call it the white coat syndrome, which is where heart rate and blood pressure can increase, or at least all different vital signs can change as a result of the white coat, in other words, the doctor. So just the sole presence of a doctor might cause them to have a higher heart rate or blood pressure. And adults with a heart rate of 50 or 45 in rest, as long as they are not short of breath, it's likely physiological and a result of them being an athlete. Athletes have, on average, heart rates that can get close to 60 or even 50 in rest. And they are not abnormal, they are just different shades of normal. Then we have blood pressure. And for blood pressure, we really know what those values should be. And blood pressure is defined as the average pressure in your blood vessels at different times of the heart cycle. And the heart cycle is the different steps that our heart undertakes in order to contract and then, of course, send the blood through the body. Now, you do not have to know that entire process yet. That's not what this video is for. You just have to know some basic values. So the average or normal value is 120 over 80. And the 120 stands for the systolic blood pressure, or the SBP. And the 80 stands for the diastolic blood pressure, or DBP. We say 120 over 80, and that's fairly normal. And the unit is millimeters mercury. So the systolic blood pressure should always be within 90 to 135. When it's below 90, it can be a bad sign, and it's more typical of an acute illness. If it's above 135, it can be classified as hypertension, so a high blood pressure, which is more of a chronic illness. The diastolic blood pressure is typically from 60 to 95. And the systolic blood pressure is more important in establishing a diagnosis, because the systolic blood pressure is the one that's is the pressure when the heart is actually pushing out the blood. And blood pressure, if it's low, can lead to organ hypoperfusion, which means that there's too little blood going towards these organs. And as a result of that, you can get, for example, kidney failure or liver failure. Now, the reason why I did not post the normal values for children is because in children, blood pressure is typically a bit lower, and hypertension is very rare in children. And if it is present, it's typically in extreme conditions. So, for example, an endocrine disorder, so an hormonal disorder that leads to hypertension, like a pheochromocytoma, which is a rare type of cancer of your adrenal glands, which are small glands on top of your kidney, and they can cause hypertension, or Addison's disease, for example, as well. And low blood pressure is a very late and also very poor indicator of severe illness, a severely acute illness. So, for example, in shock, in adults, blood pressure is a bit more reliable, but in children, you do not use blood pressure to diagnose shock, but you use something called capillary refill time. So that's why I don't mention the normal values for blood pressure in children. But generally speaking, you can see that you have that blood pressure is lower in children and higher in mature adults and elderly. Then we have respiratory rate, and respiratory rate is defined as the number of breaths per minute. Now, normally in adults, there's a range of 12 to 18 breaths per minute. So that's what the minute -1 stands for. It means per minute. Some people say 12 to 20. I'm okay with that too, because you do not diagnose people with a disorder when they have a respiratory rate of 11 or 21. As I mentioned before, these are all changes that can be physiological, and you should always investigate further when you see these things. A respiratory rate of 6 or a respiratory rate of 30 in an adult, both are more dangerous. than 11 or 21. Also note that in younger children, the respiratory rate is again higher. So below the age of 10, it's typically around 20 to 30. And below the age of 1, it's typically 30 to 60 breaths per minute. And that's fairly normal for newborn children. Then there's arterial oxygen saturation, or also called SpO2. It's often considered to be perhaps the most difficult vital sign to interpret. Its definition is the percentage of red blood cells is fully saturated with oxygen molecules. Technically, it's the percentage of hemoglobin, but considering each red blood cell has 4 hemoglobin molecules, it's roughly the same. Not exactly, but roughly. Now, the normal range for arterial oxygen saturation is 94 to 100%. Because when this saturation goes below 94%, your blood oxygen content will actually be so low that your body needs to work very hard in order to get oxygen to your tissues. And SpO2 values higher than 100% are unicorns because they do not exist. You cannot go higher than 100%. You cannot have oversaturation because one hemoglobin molecule can only bind to a limited amount of oxygen molecules, I think only 4 as well. So you cannot have more than that. There's only space for this much oxygen in your blood, and so it cannot be higher than 100%. Please also make that clear to your patients when they say that their SpO2 is higher than 100. And then finally, there's body temperature. Now, body temperature is also an interesting one. So it's the temperature in Celsius or Fahrenheit of the internal body. But the normal range we typically assume is that of 37 to 38 degrees Celsius or 97 to 99 Fahrenheit. These are rough estimates because, as you can see in the table, temperature depends on age. It also depends on where in the body you actually take this temperature. So oral and ear temperatures are typically the same, and they are relatively reliable indicators of fever. But you should note that when you take rectal temperature, this is typically 1 degree higher, both in Celsius and Fahrenheit. And when it's axillary, so in the armpits, it's typically a degree lower than normal. So when you measure temperature axillary, add 1. And when you measure it rectally, deduct 1 in order to get an approximation of oral or ear temperature. Usually we take oral temperature. Ear temperature is also really nice. Ear is especially very useful in little children because they cannot take things into their mouth. Rectal, they often don't really find nice. And axillary, they don't sit down enough for that, and you prefer to take ear, which is the most reliable one, than doing axillary and having to add 1 degree, which is still less reliable than just taking an ear measurement. So those are the 5 vital signs. And finally, we'll be discussing advanced traumatic life support, or ATLS, which is less about emergent patients, but more about traumatic patients, so when they actually have severe injury. So ATLS, or advanced traumatic life support, are essentially 5 steps, although not really steps, in assessing a critically ill patient. And we also call it the trauma ABCs. And the trauma ABCs stand for A, B, C, D, and E, which in itself stand for airway, breathing, circulation, disability, and exposure. So airway, or the A, is defined as the patency of the airways, so whether the airway is open or not. As you can see on the right, the airway consists of the oral cavity and the trachea, and then the bronchi and then the lungs. So the trachea has to be open or patent in order to have an open or patent airway. And this is important, of course, because if the airway is obstructed, you cannot administer oxygen, or the patient cannot breathe, essentially. And there's different causes that might lead to an airway block, for example, a foreign body aspiration, which is where a little kid, for example, ingests a battery which gets lodged into the trachea or in a bronchus, and as a result of that, they'll have problems breathing. Anaphylaxis is a severe stage of allergic reaction, and it can actually cause the tissues around your throat to swell up, and as a result of that, you'll also have an obstruction. And then there's the pneumothorax, which is when one of your lungs is unable to expand because of injury to the chest wall, which means that the pressure around the lungs is the same as the pressure outside of the lungs, so in the atmospheric air, which should not be the same because the lung likes to be or has to be stretched by the chest. So it's essentially a collapsed lung. Now, treatment when the airway is compromised is typically by intubation, which you can see on the image on the right, which is where, by means of a laryngoscope, you actually push down the tongue and make sure that you can enter a tube freely. This doesn't always work. So, for example, in the case of a foreign body aspiration, the obstruction might be so large or so extensive that it's not possible to do this, in which case you have to do a tracheostomy. In severe cases of anaphylaxis where intubation is not possible, you also do a tracheostomy. And in pneumothorax, although we do always intubate, because the lung is collapsed, meaning that we cannot expand it, giving a patient oxygen is often not of real additional value. It does add, but it's not a significant amount that's added, although we still, of course, do it. A tracheostomy, by the way, is where instead of entering a laryngoscope, what we do is on the throat, at the side of the trachea, we actually make a small breathing hole and add a tube to that to keep that hole open, which is typically temporary, but it's a really, really severe intervention, and you really, really want to avoid that. And for intubation, a patient is typically unconscious and also sedated. And you also typically use muscle relaxants because patients, well, let's just say intubation is not that nice to have in your throat. Breathing, or B, stands for the ventilation of the lungs. So breathing is not necessarily whether the areas are open or not, but it's whether you are breathing, so respiring, whether there's air that's being exchanged from the lungs to the outside and the other way around, so that gases can move, so that oxygen can move into your body and carbon dioxide can move out of your body. Potential causes of breathing disorders are comatose state or paralysis, an asthma exacerbation, or an acid-base disorder, which is defined as disorders of the CO2 in your body or the bicarbonate in your body. Those are very specific disorders that you will learn about later, but especially when you do emergency medicine rotations. So for now, it suffices to say that it's a disorder of release of carbon dioxide or excessive release of carbon dioxide. Now, treatment can consist of intubation or tracheostomy in some cases, although some patients prefer or can be treated better with acute relief medication. In the case of asthma, what you could use is something called salbutamol, which is a type of medication that causes the muscle in the or around the trachea to relax and also around the bronchi to relax. And as a result of that, there's more space to breathe. And finally, there's fluid correction in case of acid-base disorders, for example. Then we come to C from circulation, which is essentially the cardiovascular status. So airway and breathing together are the respiratory rate and the SpO2. And now circulation is the blood pressure and the heart rate. Now, potential causes of circulatory disturbances are acute blood loss, heart failure, pericardial effusion, or ventricular arrhythmia. Pericardial effusion, as you can see on the image on the right, is where there's fluid or body fluid that collect around the heart, which can be the cause, or which can be caused by an infection or by bleeding or by certain other lung conditions that might lead to this. Also, some cancers can actually cause this, which is called a paraneoplastic syndrome. So it's where the cancer causes additional symptoms that are not associated with the cancer itself. Ventricular arrhythmia is when the ventricles of the heart, which are the bottom part that actually push the blood back into the lungs or into the systemic circulation. And arrhythmia is when the rhythm in these ventricles is irregular. So the heart doesn't adequately contract, and instead it either shakes or it contracts uncontrollably. In both cases, you can have cardiovascular collapse. There's different types of treatments we can use. So we can use fluid correction or blood correction, for example, in case of acute blood loss. We can also use diuretics, so that's a type of medical treatment, which actually help you get rid of a lot of fluid very quickly by your urine, which is often used in heart failure and in some cases also in pericardial effusion. Pericardiocentesis is where you inject a needle into the pericardial space, which is the space around the heart, and get rid of the pericardial effusion. It's not something we do while on site, so it's not something we do outside of the hospital. We always do that inside the hospital, where we work with sterile fields, so we can guarantee that this does not cause a pericarditis, which is an inflammation often caused by an infection of the outer layer of the heart. And then there's medical treatment. So we can, of course, give medications against heart failure and against ventricular arrhythmia. Then there's disability. And the D of disability stands for neurological status and fractures. So anything that causes a disability. Potential causes are an acute fracture of the hip, a traumatic brain injury, or intoxication, seizures, and a meningitis. And a meningitis is an inflammation of the meninges, which are a very thin protective layer around the brain and spinal cord. And when that gets infected, it can cause severe disability. So these conditions require typically in-hospital treatment, and it's difficult to treat these on site. And the way in which we check these is by something that's not a vital sign, although emergency medical services often do consider this a vital sign, which is your pupillary reflex. So you can use a small lantern to test for the pupillary reflex, which can often be a sign of neurological disability when the reflex is not present on one or both sides. The treatment is typically by fluid correction and internal fixation, as well as general supportive treatments. In case there's bleeding in the brain, you can, of course, relieve that by emergency surgery. In case there's infectious disease, or such as a meningitis, or in case there's seizures, you can also give pharmacological treatment. And then finally, there's the E of exposure. And exposure typically comprises of infection and hypothermia, so a low body temperature. Potential causes include an open wound, which of course can cause the infection, and a cold area, or in some cases, excessive blood loss. Both of these can lead to hypothermia. And treatments, when these are compromised, consist of prophylactic antibiotics. And prophylactic means that we treat patients just to be sure. So we're not sure whether the patient has an infection or not. So, but we're going to treat them regardless because we think that it might prevent them from getting an infection. Adequate wound treatment and preventing hypothermia, for example, by adequately treating these wounds and keeping the patient warm, also help with this. In case of burn wounds, you also have to supply the patient with fluids because burn wounds release a lot of water and can cause severe dehydration in a patient. And as a result of that, hypovolemia and then also circulatory collapse and a lot of problems from there. So how do you put ATLS in practice? So ATLS is rather difficult to do when you're not used to it, and it's unlikely that you, as a PGY1, will immediately experience a level 1 or level 2 trauma center. So there's a couple of things you could still remember in order to at least be able to help out at the emergency department, where they also apply ATLS in urgent or emergent cases. Or in case you are later put into practice at the trauma department, it might be useful to know this. So there's 4 tips I can give here. First, follow the steps of ATLS in exact order. Do not start with circulation. Do not start with breathing. You start with airway. The only exception is currently open and bleeding wounds. If they're not bleeding, leave them be, because they are part of E, exposure. We care more about the airway than the risk of infection, because if we do not save the airway, we do not have to save the infection, because the patient will be dead. Secondly, do not continue until you're sure that the step is completed and stabilized. So do not make half work. Do not think, well, the airway is probably patent now, so I'm just going to go to breathing and check the breathing. No, you always make sure that the airway is not obstructed, or if it is, you make sure to intervene. Third point is that if you don't trust it, go back and redo the step. And also, when you haven't checked in on the airway for a while, and you're now busy with circulation, it's fine to finish circulation and just go back to A. Just go back to airway, redo the airway, make sure that everything is okay, then go back to B, breathing, then go back to C, and after that, go to D, disability, and E, exposure. D and E are typically done in the hospital itself. So it's A, B, and C that are often most important in care outside of the hospital, but also generally speaking, these are the most common kinds of disorders that you typically notice. Also, even if you know the patient has cardiovascular collapse, and when you can have an educated guess on that the patient probably does have a patent airway, and you do not have to worry about that, you still check the airway. You do not skip a step, because there always might be something wrong. And lastly, ask for help when you're lost. Don't be afraid to ask for help, because you're dealing with human lives here. So, we discussed the organization of Emerus Medical Center, admission and primary survey, the care request exploration, vital signs, and advanced traumatic life support. So, you can do the review exam to test your knowledge of this video clip. This review exam will be available after this video is uploaded, and it's a small exam for which you are not graded, and we do not store the data for further usage. It's just for you yourself to check whether you think you know everything, or whether there's things you need to brush upon or ask questions about. And on the right, you can see an example question. And showing the information you retain from here during shifts will increase your likelihood of getting promoted to PGY2 when you're a PGY1. So, thank you for watching. I hope you had fun, and I really, really hope you've learned something from this. And if you have any questions, feel free to contact me on Discord, either privately or in the group chat medical staff.